So Sally and I are going to do this next session on feedback. I'm Susan Promes. I didn't get to meet all of you this morning because I was at another finance committee. It would have been much more fun to be with you guys, but sorry to be there. So I'm excited to spend a little bit of time with all of you. I'm currently the chair of emergency medicine at Penn State. And prior to that, I was a residency director for 15 years and started 2 different residency programs. So medical education is very near and dear to my heart. So I'm excited to be able to spend a little bit of time with you this afternoon. I was going to say, is it morning? It's not morning anymore. It's afternoon. Do you want to? Good slide. So we're going to start off first with this session on feedback to really talk about what your kind of images are, what you think about when you think of really good feedback. But frankly, I think what people remember most are the bad experiences they've had with feedback. So how about we start with the bad things? Like, what are the things you remember like, oh, that was just really not good? What were the characteristics?
Non-specific.
Okay. So what was non-specific? What, just nondescript, or do you remember the scenario?
No, that's kind of a vague statement, but more just that, like if someone says, you need to read more, then it's like, okay, well, what exactly do I need to read more about? Like the pathophysiology, the management, and then you don't know how to improve when someone does it. They just tell you a very general statement.
So a good characteristic of really good feedback would be something that's very specific. What else? Poorly timed. Do you want to talk a little bit more about that?
Yeah, I think it can sort of go either way. It could be way too early if it's in the moment. If you're like in a resuscitation or something, or just immediately post, and it may not be the right time to hear it might not be the right time in that moment to hear hear that feedback. Or conversely, if it is a rotation evaluation or something that doesn't hit your inbox until a month or 2 months later, then it's way too far out for you to have any kind of useful action on that feedback.
So I want to say something about that, and I don't know if you guys can relate to this, but timing is important for the receiver of the feedback, but also the person delivering the feedback. So if you're really upset about an interaction, like it gets you upset, you probably need to take a little bit of time to think about that before you have that discussion with the learner so they can process it in a way that's really helpful. I mean, I know I've had times I'm like, we need to talk about that case, but hey, why don't you come by tomorrow, my office, and we can sit down and chat about it, rather than right then, because that's just not the right time. And it gives you time to think about and process it, as well as the receiver. They can start thinking about how things go or went. Other thoughts?
Kind of following on from your timing, a situation thing, all right? So praise in public, discipline in private. If your resident's messed up a line or really got the diagnosis wrong, don't pull them up in front of the nursing staff, the other residents, in earshot of the patient. Do it somewhere that's situationally appropriate. Good feedback you can do both ways.
One of the things that I fumbled when I gave feedback recently was that it was, going back to your point, it's like not in the right time. So the concept of is the learner in the surviving mode? They're just trying to finish their shift because they're really tired, or they're actually thriving and it's a prime time for them to learn more. So asking permission, hey, I have something to tell you. Is this a good time to talk about it? And then allowing them to really own up that responsibility, that if they say no, then have them schedule the appointment to meet with you to follow up.
Others? So we've heard timely, specific, really descriptive, right, rather than kind of just general terms. Other things? Other things you can think of?
Sure. I try to make it actionable. So when I give them feedback, I'll tell them what behavior they had that has either made me happy or disappointed me, and then we work out some way that they're going to fix it. Like you said before, read more, right? Read more is everybody needs to read more. It's not really actionable. But if I tell them I want you to use more open-ended questions when you start your history because they'll be able to tell you a better story, then I've given them a piece that they can do specifically.
Great.
Really focusing it on the behavior itself, not leaping to conclusions about them as an individual, what it means about their personality or their capacity, and just really kind of honing in on that item. It gets to actionable, but it also gets at the mindset of why you're trying to give the feedback and what you're focusing the feedback on.
Yep. So one of the things, just to add on to that, is really if you can describe to the individual what you observed and what was good about that and what wasn't good about that. And frequently you'll have, I don't know if you guys have this, but when people write kind of written evaluations, they're not as detailed, and it's hard for people to remember it, especially if it's an end of rotation and it happened a few weeks ago. So as clearly as you can describe what happened, the better. I left, or Sally put on the table for all of you guys, a handout that's got a list of really good characteristics of constructive feedback. And I just want to kind of look through them together and see if we can highlight any of the other ones that maybe we didn't come up with. But I think you hit on many of them. We talked about being descriptive of what happened rather than putting some evaluative component on it, specific rather than general. This is one we didn't talk about, but the thought of if you're doing feedback, it's a two-way conversation, and ideally you start with some kind of agreement. Do you remember when we were in the room? Do you remember what was going on there? So kind of bring the learner to the same page that you're on as the evaluator. Focus on behavior, so ideally objective things, not on the person. Again, kind of what you said, Sarah. Let's see. Direct feedback towards behavior the receiver can change, right? You can't change if you're tall or you're short, but you can change how you approach that patient. Maybe if you're doing CPR, you should step up on the stool because you have to, come over the patient. So you give them a way to do it rather than saying, sorry, you're too short, right? So you want to think of it that way. Share information rather than give advice. I like that one because if you share the information about a situation and you can get the learner to the right place so they can process it and own it and want to change, the better, right? Rather than you telling them they need to change. If they can come to that conclusion themselves, it's really helpful. What else do we have listed here that might be valuable to the group? Check to assure clear communication. Have you ever had a discussion and the other individual just didn't get what you had to say? So you really want to check for that and make sure they understand the message that you delivered to them. And remember, people can only take so much, right? You don't have to tell them everything that they did wrong, right? We all have some of those learners, hopefully not many of them, that you're just like, oh no, right? But give them one thing at a time to work on and praise them when they get those things right so that they can work on kind of the next thing. There's a couple other things on here that you guys can look through that might be valuable for you at another time. But does anybody else have any other thoughts about constructive feedback? Yeah.
Just one more thing, because I've been trapped by it. Often after we've discussed the behavior that needed to be changed and everybody's agreed that that behavior needs to be changed, my next question is, why do you think that happened? Because often I've identified a behavior and I'm about to tell them how to fix the behavior, and they already know they did it wrong, and they already know why they did it wrong. They may say, yeah, I yelled at that patient because I got frustrated by my last 3 patients. I shouldn't have let that happen. I should have, right? They've already fixed it in their mind. And my telling them what they did wrong and pointing it out and being in the senior position, they're like, now I feel even worse. I already knew I did it wrong. I already knew I needed to fix it. But now you've pointed it out and made it worse for me.
So what do you say to them?
I say, why? Why was that behavior? Why did that behavior happen? Right, so we can work towards it. And sometimes they've got a very good explanation, which in all honesty, I've done before, and I'm like, yeah, I've been there. Just got to watch that and try not to do it.
Yeah. Other thoughts or comments? All right, Sally's going to walk you through a process for giving feedback. Do you want to use this, Sally?
All right. So who uses the feedback sandwich? No, good, good. So for those of you who have had it, my chair used to do this excellently, not at Michigan, but he used to sit me down, like I called into his office, and he'd be like, Sally, you're one of our best clinicians ever. And then he would tell me all the crap that I had done and basically, you know, dump on me. And then at the end he would say, and I'd like you to take care of my family. And about, you know, I can't tell you how many times, but the bun was always the same and the shit was always what he really meant. And so you knew that when you, right, it just doesn't work. And so I would encourage people not to do the feedback or the shit sandwich. So here's another model that we can use. All right, so this is 4 steps for giving feedback. What I like to think about it is as first prepare, so think ahead of time about what you're going to do, ask for the learner input, share, meaning have a conversation, and then think about what the action plan is, so agree on a plan. And so here, just working through the steps a little bit more detailed. So first, kind of prepare. What do you want them to know? What do you want them to take away from? So similar to any talk that you're giving, get a sense of what do you want to change? What are your goals for that conversation as you go through it? Make sure that it's private, it's timely, it's expected, it's sensitive, it's based on specific feedback, all those things. But prepare, be ready for it. The next step is ask for the learner input. And that's the what do you think happened? You know, why do you think this happened? What behavior did you do? It's their assessment of what happened during that time frame. This one is really key, and there's a couple of reasons for that. The first one is that we know from multiple studies that self-assessment is poor, is that everybody thinks that they are above average. You know, my little dog, she definitely thinks she's a wolf. She takes on like the Great Danes thinking that she's this huge dog. But it is to say that that's true across multiple domains. This is a lovely study that they've now done into a verb and an adjective. It's the Kruger and Dunning disease. I don't know if you all have seen it. It's hysterical. But essentially what it is that on the left-hand side of the slide are the low performers, the bottom quartile performers. If you ask your bottom quartile performers how they did, they will almost always say they're above average. Your top performers on the far right will actually say that they were below what they actually performed. And so this has been shown multiple times, multiple domains, et cetera, et cetera. What's scary to me about this is that we all exist on the bottom quartile in something that we think that we're above average on, and we don't know which one that is. And the only way to know that is to get feedback or to have informed self-assessment. And so when you're doing this conversation about self-assessment, your purpose is to figure out where they think they are, because occasionally there'll actually be some insight. And so that's the purpose of self-assessment. Once you get into your self-assessment, you're then into this space. People will commonly talk about positive and negative feedback, right? Or constructive feedback versus positive feedback. That's actually probably not the right way we should be thinking about it. The feedback workers, or the people in this space, are really talking about confirming and disconfirming. So if you say, Sally, or Meg, no, since Meg tells me, Sally, you are terrible at putting your slides together on time. Yes, I am, right? And so you have confirmed, you've given me negative feedback, you've confirmed what I already know, and so our next step is to how to get Sally to do her slides on time, because she doesn't do it. If, on the other hand, Meg says to me, Sally, that's a lousy slide. It's got red, it's got yellow, it's got terrible stuff. I'm proud of that slide, I made it myself, right? That is disconfirming to my own sense of myself. And so you're gonna have to actually struggle with me or show me enough evidence so that I actually believe what you have to say. So the purpose of the self-assessment at that very beginning of asking how people are doing is to get a sense of, are you doing the struggle to try to get them to confirm, or are they already in that confirming space? Because if they're still in disconfirming and not believing what you have to say, you might as well walk away, right? My favorite example was I worked with this resident a couple of years ago, and at the end of the day, I said to him, you know, we did our usual feedback thing, and I said, you know, I'd kind of like you to be nice to patients. And I gave him a couple of examples, et cetera, et cetera. And then I worked with him like a week later, and at the beginning of the shift, as I always do, I said, so what are you working on today? And, oh, he's working on his this, that, and the other, right? His efficiency and reading EKGs and monitoring his students. And I turned to him and I said, well, what about being nice to patients? He rolled his eyes and walked away, right? I was disconfirming, and I never got to him. So unless you can get somebody to confirming, then you're not going to get anywhere. And so be aware of that kind of, that's the importance of this, of the ask part, okay? Questions on that? Okay. And so just reviewing, if it's confirming, then you work directly to your action plan. If it's disconfirming, you're going to spend time trying to figure out how you can get them to understand where you are. Okay. So step three is share. So that's the have a conversation, and that may be the conversation about what happened. That may be the conversation to try to get them to get to confirming, but have a conversation, and it should be a kind of a give and a take. You want to be providing good examples and based on data-driven things that you can change. And then finally, come up with an action plan. And so remember, if we go back to our pyramid, you remember 90% of what you said yourself or you're going to do yourself, and 10% of what I say. And so action plans are much more effective if they come up with it themselves, rather than me saying to you, I think you should do this, because I'm not you, and you're not going to own that. And so it's much better for people to come out with their own action plans. Okay, questions so far? Okay, practice. Remember, we're using the Kolb's learning cycle. We used your prior knowledge. That's what Susan did. We just provided you some new knowledge, and now we're just going to do it. Okay.